would be worthwhile just to do a round of names, but otherwise happy just to introduce myself and my colleague from the National Unit. Any thoughts on that? No, I'll take silence as consensus. Okay, so my name's Sue Hilsden. I'm a Quality Improvement and Development Lead with the FNP National Unit, and I'm joined by my colleague Andrea. Andrea, do you want to introduce yourself?
Hello everyone, I'm Andrea Kalin. I'm Head of Data and Analysis at the FNP National Unit. And yeah, nice to see so many of you joining us today.
Okay, so just before I share my screen, so the purpose of today, which obviously has been a bit delayed because of the elections and the period of sensitivity, was to present the findings from the latest research for FNP that was published in February. It's just to go through the findings with you and then a space for a discussion, any questions, thoughts, reflections really at the end. So I'm going to share my screen. Let's hope it's going to. It was being a bit temperamental this morning, Teams. Can everybody see my screen?
Yes.
Yeah.
Yes, so.
Great. Okay, let's put that on the slide slow. Okay, so while I'm presenting, as you know, on Teams, I can't see you. So as I say, there will be a chance for questions at the end. If you want to put anything in the chat that we can catch up, please do. So I think we've got an hour and a half today, so I think there's plenty of time for discussions at the end. Okay, so the building blocks 2 to 6 research provides new evidence of impact for FNP in England. Today, as I said, we're going to go through the study, a bit of background about the study, go through the key findings, some elements of the responses to those findings, and time for discussion at the end. Okay, so about the study. So the building blocks 2 to 6 was a follow-up of an original RCT that was carried out earlier. Results came out, published in 2015, but that RCT covered the first couple of waves of FNP in England, the first 2 years that the programme was up and running. And this trial follows those children, those original children from that RCT, and follows them through to Key Stage 1. Those children are probably about 10, 11 now. So the funder was the National Institute for Health Research. It was carried out by Cardiff University. As I say, it was published on the 10th of February, and there's a link to the NIHR website where you can gain access to the full report. Okay, so as I said, the cohort Children and Mothers was a follow-up from the existing trial, and this study uses routine data, so it doesn't cover any qualitative data. It was all gathered from routine data from national data sets. It's just over 1,500 teenage mothers, and women were recruited in pregnancy from the original trial, and half the participants were randomly selected to FNP and half were received usual services at that time. Okay, so the data sources that were used in this study, so maternally reported baseline data and follow-up data collected as part of the original building block study, hospital episode statistics for admissions and A&E attendances, national pupil database for social care and educational data, and abortion data from Department of Health and Social Care. The rates for matching the the children to the database, it was really high. So 98, 97% match data across all the databases. So a really robust a set of data and a robust study, which is large for its kind. Okay. So key findings. So the first set of findings focus on education and early years. And the findings found that the FNP does improve child development and school readiness for age 5. And this is looking at early years foundation stage data. So a greater proportion of children in the FNP arm achieve a good level of development across the 5 combined areas of learning for children aged 4 to 5. And a greater proportion of children in the FNP arm achieve at least the expected level for all 17 learning goals at age 4 to 5. The impact for improvement for the FNP cohort is statistically significant. And if you then look at the adjusted odds ratio for the 5 combined areas is 26%, and for the 17 learning goals, 24% improvement from FNP compared to usual children in usual services. So that's just to confirm the adjusted odds ratio. So by 26% of the 5 combined areas FNP, the chances of FNP children achieving a good level is increased by 26% and 24% for the 17 learning goals. So looking at Key Stage 1, what we find is that this impact persists, and at children reaching age 7 and looking at the Key Stage 1 data for reading, a greater proportion of children in the FNP arm reached the expected level in reading. And the adjusted odds ratio takes account of controlling for birth month, and I think it also adjusted for things like preterm births and gestational age. And quite interestingly, that there was some sub-analysis from this group for Key Stage 1, and it found that the FNP programme had effects for boys in particular around writing and reading, for children of younger mothers for mathematics and writing, and children of mothers who are not in education, employment and training, also for writing. And what the study found is that the intervention effect was stronger for children whose families had more visits from a family nurse. And so taking into account the odds ratio, the FNP increased the chances of children achieving the expected standard in reading at Key Stage 1 by 38% compared to the children in the usual care. And I think this finding is quite interesting, is actually the study found no difference in the type of early years that the children accessed, either in FNP or in the control arm, or in the patterns of educational attendance. So there was similar attendance at early years education between the ages of 2 to 4 in both arms of the trial. Okay, so moving on to the social care, which is one of the other elements that the study looked at. So for social care, the study found that the children in family nurse partnership arm were just as likely to be referred to children's social care and registered as in need or placed on the child protection register as the control arm. So there was no significant difference between both arms of the trial for all of the social care interventions, referral rates, or children going onto plans or into care. You can see from the slides there's some very slight differences, but not statistically significant. However, there were some nuances to that data, and again, this is not statistically significant, but does look at children in the FNP arm were referred less multiple times. Children in the FNP arm were 90 days younger on average at referral, and FNP children spent on average 2 months less in care, less time in care than children in the usual care arm. But again, as I say, that's not significant, statistical significant data, but is interested, and we're quite curious about that ourselves. Moving on. For healthcare resource, again, there wasn't any notable differences between the usual care arm and FNP children. What they did find that the resource use for healthcare was slightly lower for the usual care than FNP, but costs were higher. So suggesting maybe a higher cost, more complicated visit for those under the usual care. But overall, there was no significant differences. And in terms of cost, there was no significant difference in cost. There was no full economic evaluation of the programme as part of this study, and no cost analysis on primary healthcare, education or social care outcomes were done. And there's no cost utility analysis to identify the impact on the quality of life, and there was no subgroup analysis as part of that. We remain interested in having some kind of economic evaluation of FNP, and that is something that we are exploring with PHE, maybe for the future. Okay, so in summary, what this study shows us that obviously there's clear evidence that FNP improves child development, school readiness and early education attainment. FNP children were as likely to be referred to social care than usual care children. Evidence of mid-term impact for FNP in areas that directly address inequalities of life and chances for children and closing the attainment gap. And any cost consequence analysis found no difference in secondary healthcare costs for mothers and children in both arms. So we've had a couple of responses from the Early Intervention Foundation around this study, and they've looked at the improved cognitive outcomes and said they're rare for these type of programmes, and there was only 5 out of 20 assessed that had any evidence of improving cognitive outcomes. And FNP was one of those 5 that has evidence of improved cognitive outcome lasting 5 years or longer. And the EAF said that's quite a rare finding. Also, the Early Intervention Foundation say that through long-term evaluation that we now have important new UK evidence that FNP has the potential to improve the life chances of highly vulnerable children and improve their cognitive development. And these are important outcomes as we know that cognitive capabilities in the early years are consistently associated with children's success at school and entry into the workforce. And I think you can see, if you visit the EIF website, you can see their response to this study on there. I think there's a blog that's been written as well, which is an interesting read. Okay, so in terms of what next for FNP and what this means for FNP in England, particularly, evidence of impact for FNP in areas that directly address inequalities of life for chances for children, and that's really significant, particularly at the time we are at now, and evidence of actually closing the attainment gaps for vulnerable children in terms of looking at as we come out of the pandemic, the harms that we know that we've seen for children during this time, the attainment gaps that we know persist for vulnerable children. So the evidence for FNP and how FNP as an intensive home visiting early intervention programme can make a difference to these children, I think is really important information for us to have. So we're curious about the fact that the study found that FNP having FNP did not change the likelihood of children needing children's social care intervention. Obviously, as I said, this study builds on from the original RCT and the children who originally enrolled on the programme 9-10 years ago. FNP has not stood still since that time, and especially over the last 3 or 4 years, we have been working on a project called ADAPT, where we have implemented changes to the programme which reflect greater understanding of the vulnerabilities of the mothers and children on the programme and the value of a trauma-informed approach. We've developed programme adaptations focused on neglect and intimate partner violence, and we plan to implement those more widely over the coming year. Early evidence from our ADAPT project, and the ADAPT project started in 2016 and completed in 2019. There is a full report of that project on our website. It's published in March 2019. March 2020, just before we transferred into PHE. And that ADAPT project was developing a more personalised approach to delivery of FNP. We worked with Triangle Consultancy to develop a new Mum Star. And so the programme obviously continues to be a manualised programme, but can be personalised to individual client need. And the programme can be flexed depending on the needs of the client. And part of the evaluation of the ADAPT project and the personalisation of the project showed that a smaller proportion of children in the sites had social and emotional development outside the normal range compared to the sites not implementing the personalisation. So during the ADAPT project, we worked with 20 sites to develop the new service delivery model. And since August of this year, we have started to roll out the new model of delivery to all sites across the country. So this signals potential added positive effect that personalisation in fostering optimal child development will have within the programme, and obviously we will continue to monitor that as we roll out those changes for the programme in all sites. So in terms of the national unit, we continue to have strategic oversight for the development and support for local delivery of FNP. We transferred to Public Health England in April 2020, and we will go along with our Nursing, Maternity and Early Years Directorate to wherever our new receiver organisation will be. We will be expanding the remit of the national unit to take on national leadership of intensive parenting support, looking at evidence, policy and implementation. We want to realise the potential of the intensive parenting support programmes to improve life chances and contribute to best start in life. And as I said before, this is timely in terms of response to the pandemic and hidden harms, and what we can offer to the response to that. Okay, so that's a lot of information I'm aware of to take in. I'm quite happy to go back to any slide if you want me to. If not, I will stop sharing so we can have a conversation. Just to the last slide, and obviously these can be sent out. If you would like any further information about the work that we've been doing in FNP, the ADAPT, our Key Skills and Knowledge Exchange programme, for example, and how we've been working to support an integrated and collaborative approach to support vulnerable families, then please do email us, and we're quite happy to have a follow-up conversation individually with sites and different local areas if that's helpful. Okay, so I'm going to stop sharing. Turn my video off there, didn't mean to do that.
Yes, so Kate was just asking whether the slides will be shared, and I just responded that I'm sure that it won't be a problem, I don't think. Yeah. And also Andrea said that a cost benefit analysis would have been helpful. That's Andrea Westlake, but Andrea Kaelin has responded that the limited economic analysis also reflects the fact that it is very difficult to cost less tangible benefits such as well-being and education. So So I don't know if there's anything else that you want to add to that. That's all we've got in the chat so far.
Yeah, I mean, yes, we will share the slides. We'll get them PDF'd and sent. If I sent them to you, and then you can forward them on. Andrea, did you want to say any more about the economic analysis? Or
I think Andrea had her her hand up. If she,
okay, Andrea, yeah.
Hi, thanks, Sue. I mean, I'm delighted, having commissioned FNP for a number of years before I left the NHS in 2015. You know, across Staffordshire, Shropshire. So I'm thrilled to hear that there's some positive outcomes out of this. It's very emotionally satisfying for me. Let me tell you that, because I'm a great believer in it. I just wonder, actually, where are we in the state of play now with FNP? How widespread is it? You know, how many nurses have we got practicing in this area? You know, how many families basically are we looking after? Where are we? What's the state of the nation, as they would say? Where are we at?
So as from the 1st of April, we have 59 sites across the country.
Okay.
In different, so 59 local authority areas. There was approximately, and Andrea will probably be better on the numbers of clients, I think it's about circa 5,000 clients currently on the programme. And as a guesstimate, I would say between 300 and 400 nurses.
Yeah. And how has that changed over the last few years? What's that?
It's about half of what. So we reached out. We were contracted originally to deliver 15,000 places across the country by March 2015, and we overachieved that in over 120 local, 120 sites. I wouldn't say 120 local authority areas, because some were based on old sort of PCT sites and things like that. But
yeah,
so we've seen about half be decommissioned over that time.
About half.
And the majority of that has been down to financial constraints, I would say.
Yeah. But do you think this study it gives a glimmer of hope? Do you feel? Or?
I hope so. I think, you know, in terms of the evidence of this study, you know, and this is so important, isn't it? And I agree with you, Andrea, and I would say that, of course, I work for FNP. But in terms of actually the work we want to do going forward, you know, then now that we've been brought back into PHE, our remit will be widening out to take on a national lead in terms of intensive parenting support within that early years, sort of 1,001 days space. I think this evidence is really important data in terms of the that early years education attainment for those children. That actually something, you know, it's accounted for younger children, it's accounted for all those children had similar experiences between 2 and 4. So there's something that FNP is doing that is having an impact on those children in terms of building that early nurture, that early scaffolding, that early attachment that is making a difference to when they get to school.
Okay.
And what's interesting is the social care, and we're really interested actually the study didn't go into what the experience of those children were as such, and we're interested in that sub-analysis. We know it's not statistically significant, but in terms of spending less time in care, not having re-referrals, that actually is there something around how those clients work with other professionals and engage maybe in working with other professionals that.
I mean, the educational standards is significant, because if those children can compete, you know, in the job market, ultimately, then that's the one of the best things we can do. the thing for me was the safeguarding element. I was expecting it to be better than that. But then, you know, these are in challenged families, you know, so maybe we should be realistic, I guess.
Yeah.
Yeah. But I guess that's the thing for me. But educationally, does, you know, how high have we lobbied this to members of Parliament, Gavin, colleagues, to say, you know, this is working. You know, what are we doing in that space? So,
yeah. Well, I think one of the positives of us now being part of Public Health England is that this has been heard at the highest level. You know, there has been a ministerial submission on the findings, and we were also able to contribute to the Leadsom review.
Yeah, I was going to say, is it Andrea Leadsom? So it's going through.
Yeah, so we've contributed to all of that, and we've also been able to contribute to all the COVID work cells in terms of what has been the experience of vulnerable families and vulnerable children during the pandemic. So yes, we've been probably open to channels that we probably wouldn't have been if we'd still been contracted out into an NHS trust. Yeah.
And linkage into the Institute of Health Visiting. Is there any linkage?
Yes, there is. Yes.
Good.
Yeah.
Okay. Yeah. Oh, that would be good. I mean, it'd be good to stay in touch with you, if I may. I don't know whether we've got your email address. If you want to pop it in the chat, because I've got to leave now. But yeah, I am delighted actually that. So what are you saying generally? Is it's generally more positive than negative.
So in terms of the education outcomes, yes, and Andrea may want to jump in with the statistical stuff. I think a nice analogy, and I like analogies, is, you know, if there were 100 of usual care children, there'd be 126 FNP children who were school ready and ready to learn. And I always think
say that again.
So in terms of numbers of children, I'll make sure I get this right. I'm looking at Andrea's face to see if I get this right. So if there are 100 usual care children, there would be 126 FNP children who were school ready. So for me, if I started my life working in education and early years, and you think of a form of entry for school, that's a form of entry of children who are school ready, over and above the usual care arm. So it's amazing, yeah.
I think that's phenomenal, fantastic, and thank you for all the work you've done. It's amazing. I'm really pleased actually. I'm almost speechless because that last report came out. We were just devastated that it didn't demonstrate. There was flaws potentially.
And happy to have further conversations with you, because we've not stood still since that RCT, you know, and we've looked at other things such as smoking cessation during pregnancy. We've carried out quality improvement work around that, and we've got really good outcomes on the work we've done around smoking cessation. A small QI project that we did that's had positive results. So so absolutely quite happy to have a further conversation with you, Andrea. Work that we've been doing, so please emails in the chat, so please get in contact.
I'll mail you. I might see you later.
Okay, please do. Andrea, you've got your hand up.
Yes, so I just wanted to add, related to the social care data, that we know also from the researchers who worked on this study that the social care data is quite limited. So perhaps to some extent that has an impact on the findings as well, because there aren't too many details collected as part of the social care returns. So I guess just something to bear in mind when we are looking at those findings and see no statistically significant differences.
Fiona Mackison has got her hand up as well.
Oh, thank you. Hi Sue, it's Fiona
Hi,
from West
Fiona.
Sussex. Hello, hello. I mean, these findings are fab, aren't they? In West Sussex, we're just beginning a conversation about how we might try and implement ELIM, so the speech and language measurement at 2.5. And we're struggling, to be honest, just because the capacity within health visiting, COVID's not helping, obviously, what we can do in early years, and also we've got significant waiting list due to COVID for speech and language therapy. So even if you identify them, what do you do with them next? So what I've been looking at is obviously really interested in this work because we have FNP in West Sussex, is trying to unpick the FNP interventions about what it is that you do that makes the difference, because it's not just the intensity, there is something that happens, and whether that might help us to actually support speech and language at an early stage. I don't have the answer, but I'm just wondering whether it's something about, you know, the way that FNP nurses are engaging with their young parents that encourages play, attachment. You know, if there's a different way of looking at ELIM that might bring us a similar result in terms of school readiness.
Yeah, I think that's a really interesting question, Fiona. And I think, you know, FNP does focus on play and activity, you know, role models, you know, with it uses PIPE, parent in partnership education, which is very much activity based, and they role model, you know, they use the dolls, so they demonstrate all the time around you know, playing with your baby and speaking with your baby from antenatally all the way through. It might be a good idea to speak to, if I was in Shropshire, well, I wasn't in Shropshire, I was virtually in Shropshire for their annual review a little while ago, and the supervisor there was talking about the work that the family nurses had been doing to support the ELIM and the speech and language. So if I ask her if she's happy to be contacted, I'm quite happy to put you in contact with her so you can have a chat about the work they've been doing to support that rollout.
That'd be really good to see, because I need to put something, you know, got limited workforce apart from anything else, apart from money, but just trying to think about whether we can share some of this learning, and even into early years settings as well. This, you know, there's a nugget of gold in here, isn't there, that I don't quite understand.
Yeah. Okay. Yeah. I'm quite happy to put you in touch with Shropshire, who have definitely been doing some. The family nurses have been supporting the work around the speech and language and rollout. But I do think it is something about the package of FNP and the tools and resources that are used. As well as the kind of relationship they have.
Thank you. That'd be helpful.
There was another hand up. I thought I saw. Has it gone back down?
John Middleton has made a comment. I don't know if you've seen it. So he says, in the early stages of FNP in UK, it was said that controls getting usual care were being seen through usual health visiting services. So there were not the large differences between study group and the control group, unlike the original US study. Might that still be the reason there is no difference between FNP and the control group when it comes to safeguarding and social care referrals?
Yeah, I mean the children, you know, obviously this study is looking at the children from the original RCT. So this is not, you know, these are children that have gone through the system. So these children are about 10 now. But yes, I mean, even when children leave FNP, they go back into health visiting services, and if there's a risk of safeguarding, then actually all health professionals would make that referral into social care. So I think, as Andrea said, in terms of referral rate, that doesn't really tell us that much, I don't think, you know, because actually that's what we do, don't we? If there's a safeguarding risk, we make that referral to social care. I think there is more interesting around what happens once those children, you know, that you know, there's no differences in the number of children going on to plans, but spending less time. So I think that nuance is interesting. But the original, when the children were allocated for the study, it was a blind allocation. So the control arm and the FNP arm would have had similar levels of vulnerabilities at that time. So in terms of, you know, the levels of vulnerability, we know now, don't we, so much more about you know, childhood experiences, the trauma as that as, and how that pans out as children get older. So many of their clients would have very high ACEs and would have had very high ACEs, and you know, FNP is not going to be the magic fix for all of these families. You know, some of these families will carry that trauma on for all of their lives. I hope what we're seeing, though, is that something different is happening for those children, because although you've got a similar amount of children being referred into social care, there's still something going on around their education and their ability to learn. So I'd find that quite interesting. And yeah, we'll probably, as always, studies always show up more questions, don't they, as well as giving us some answers.
And Sarah Edwards has commented, I agree with Andrea and others that this is fabulous news, given the devastation impact of the second RCT study, which focuses too heavily on data about smoking cessation and breastfeeding and not on the longer term impact of the programme.
Yeah.
And
I think what we've,
sorry.
Yes. No, I was just going to say, I think what we've seen from other RCTs in America, that actually the longer the program, we do see the long-term effects, that it's a longer-term effect of this program, and hopefully that's what we're starting to see in England, with that persistent of impact from the EYFS scores up to Key Stage 1.
And then Marie McQuitt's comments, continuity of care maybe, question mark. And then Sarah Edwards responds, relationship between nurse, client and child is one of the key factors. And Elizabeth Biggs comments, continuity of care, key and priority across maternity system now too. Yeah.
And it'd be interesting, won't it, to see if we see differences in the continuity of care in maternity services generally, to see what difference that makes. But yeah, absolutely, the bedrock of FNP is continuity of care, and the same nurse with the same client is what we try to achieve every single time.
I'm sure I saw somebody who had their hand up, but they've put it down now. So yeah, that's all I've got in the chat for now. So.
Essie, I've got Sarah. Sarah's got her hand up. You're muted, Sarah.
Can you hear me now?
Yes.
Oh, okay, sorry. Yeah, sorry, I took my hand down because you read out my comments in the chat, but really it was that I now work for Derbyshire County Council, but I worked for Ripples Kick for 7 years, and we, as a small social enterprise, delivered the Family Nurse Partnership programme in Derby City, Derbyshire County, Staffordshire, with Andrea. Westlake was actually the commissioner when we were commissioned there, and we also delivered it in Worcestershire. And for me, it was just really sad, the damage that second RCT did really to people's belief in the programme. And I think that was, for us as an organisation, was a prime reason several of our commissioners stopped commissioning FNP, because they couldn't justify what they saw was the higher cost. And then those findings from that second RCT trial basically suggesting that there was little difference between the outcomes for children on FNP than children receiving universal services. But we always felt that when you looked at the American RCT information, and the fact that the programme had been running there for so much longer than in this country, it was the long-term, longitudinal studies that really demonstrated the impact of the programme. And it feels like the study that you're reporting on today is actually starting to show those things, because it's showing things that happened after the programme had been delivered, the impact on those children whose parents or whose mothers had been part of the programme. And it's really, really great to see that, and I hope to see more evidence. And I am pleased that you at least do have 59 sites still operating. That's really good. So perhaps there's an opportunity here to really promote those and hopefully encourage other commissioners to recommission FNP.
Well, if there's any commissioners out there who are interested, please come and talk to us, I would say. Thank you, Sarah.
We've got Kate Donohoe with a hand up.
Hello, thank you, Sue. I'm one of Kate King Hicks's interlopers from the southeast. Thank you very much, Sue, for the presentation. It was great. I just wondered, I just wondered what your thoughts are about the opportunities of now being part of Public Health England, and what those opportunities might do to start changing the the way in which the tide has gone, that local authorities are decommissioning FNP. So are there any opportunities about being part of PHE and the Forward organisation that you think might be able to stem that tide? And, you know, this is evidence-based, but at the same time, acknowledging the reality out there for commissioners is they have a reducing pot of money. And it's, as far as I'm aware, that's not going to change anytime soon. So I just wondered what your thoughts are for the future and how this evidence base can be used to maybe encourage more to commission FNP.
Yeah, and we acknowledge the difficulties. You know, I come from a local authority background and still have a lot of friends and colleagues still in local authorities, and know how difficult and challenges and what really difficult decisions have to be made. I think in terms of us becoming back into PHE, you know, I spoke about the opportunities that we've had that I don't think we would have had if we'd still been contracted out to an NHS organisation, in terms of, you know, having access, being able to do a ministerial submission on this study. You know, that wouldn't happen before, possibly not being able to contribute as fully as we did to the Ledson review. So I think that those are obvious ones that we are part of the national leadership there. And I think going forward, in terms of the PHE's remit letter, you know, we heard in the Queen's speech today that early years is there, and we are part of that response. The remit of the national unit will widen, so we will continue to support FNP as long as FNP is commissioned. We will continue to support it. As a national unit, in terms of the FNP part, you know, we continue to be fully funded by Public Health England, so that national investment is still there. So all the things that we provide as a national unit, in terms of all the training for nurses, so the initial training for family nurses, the training for supervisors, and then the ongoing learning, continues to be fully funded. That there's no cost of that that's passed on to provider organisations. When nurses leave and new nurses are recruited, again, that there's no cost to that training. So that ongoing learning, ongoing training is fully funded. The cost of the information system, we've just invested heavily in a new information system to support the new personalised delivery model. Again, that is fully available to anyone who has FNP, and no costs are passed on. And the people in the national units, people like myself, people like Andrea, are all fully funded from within PHE, and we're able to take on a quality assurance role. So we continue to monitor the licence, we continue to monitor that the programme is developed to high quality, and we work with sites around doing quality improvement work. So that continues. So that national investment is still there, and so that commitment is still there from a national level for FNP to be continued. In terms of looking wider, we have got a wider remit to look beyond FNP and look to looking at intensive parenting, what's needed, what is that, and working with areas, you know, that don't have FNP, that might want FNP, but in areas where FNP may not be the best fit for that area. We don't know what that looks like yet. That's early days for us, but that is our wider remit that that we have been given, and we have, you know, physical deliverables, you know, within the remit of PHE to deliver on that. So, and I think for us, one of the best things being part of PHE for the moment is having access to our regional networks, you know, which is great, and we've not had that before. So one of the difficulties we had as an FNP national unit sitting within an NHS trust, once FNP was decommissioned, our relationship came to an end really with that area. So now, you know, that we are part of PHE, we can be part of those regional networks and hopefully have a broader be able to have broader access and broader conversations to everybody who is tackling with all these difficult decisions and the growing needs within local communities and how we address them. So yeah, we very much hope to be part of that. Thank you. And as I say, if anybody did want any kind of individual conversations or you know, just interested, then say, yeah, please do email me or email the national unit inbox, and we'll be quite happy to have follow-up conversations. I saw another hand? It's gone down again. I think was it Jonathan? Did you? No. Okay. Was there anything else you wanted to add, Andrea, to anything that's been said?
I guess just to reiterate the fact that somebody mentioned earlier that it takes time for longitudinal research to be conducted, and we have to allow time to be able to see those, you know, effects over life course. And I know the initial RCT had some disappointing findings, but in the literature, the more time we allow, the stronger effects we seem to notice over the life course. And I guess for me, the findings are quite powerful because there is also research that link early, for instance, school readiness and early attainment with later attainment at GCSE level, and then earnings and even well-being outcomes in adult life. So I could already see, you know, this developing in potentially a lot of very complex follow-up studies, which would be very interesting to carry out and see, you know, what could we find out later on, and whether, you know, we could see that longitudinal effect that was detected in other studies that tracked children in US, for instance, but also with other programs, other interventions.
Great, thank you. Okay. So is there any other final reflections or questions people want to note or ask? Thanks, Kate. Because otherwise we can gift you back over half an hour of your day. I'm sure you are extremely busy people. Or you could, I don't know what the weather's like in the West Midlands or the South East. It's the sun's decided to come out in London for a bit. It's been a bit changeable, but you could even maybe go outside and get a bit of sunshine before your next meetings or your next piece of work that you need to do. But I don't want to go if there's any other burning questions. No. Okay. Well, thanks for listening. And as I say, I will send a PDF of the slides to Harpreet, and so that you can send them all out. And yeah, there'll be our contact details will be on there if you want to contact us.
Okay, that's brilliant. Thanks ever so much for hosting this for us today, Sue. It's really appreciated.
Thank you.
Thank you. Bye.
Okay,
Thanks,
bye-bye.
Thank you all. Bye-bye.